via the Jack Spring Electric Keel Newsmaker hotline. The latest of those is Dr. G.E. Ghali. He is the Chancellor at Louisiana State University Health Science Center. Hey, Dr. Ghali, welcome back to Keel. How you doing this morning?
Good morning, guys. How are y'all?
Aaron's chomping at the bit, sir, so stand by.
Yeah, Doc, we're hearing everybody, hollering and screaming now about get back to work, get back to work. Is it premature, or are you ready? Are we ready to get back to work, given the health conditions we're looking at?
Well, I don't think it's premature that everyone wants to get back to work. I think that's certainly a very good, but at this point, a little bit premature. We've got some things we need to put in place, and it's just not as like many people have said, it's not just a light switch. We can't turn it on, on and off that quickly.
What needs to be put in place?
Well, I'll just give you an example. Yesterday the governor announced his executive order to start, that we can start doing surgery again. Basically, I wouldn't use the word elective surgery, but maybe a surgery that isn't, non-urgent surgery. Up until now, for the past month and a half or so, almost 2 months, we have not been doing certainly any elective surgeries. We have not even been doing surgeries that are considered non-urgent. We've just been doing only urgent surgeries so that we can maintain capacity to take care of all the COVID patients and all the issues with that. His executive order now says that we can do that. We can begin doing less urgent surgery as well. But to do that, we're going to have to make sure we've got enough PPE in place in all the hospitals, which we do, and have an adequate supply of that. But we've also got to provide testing for all the patients that are going to be operated on. Preoperative testing. Now, this is all new. We had only previously been testing patients that are symptomatic. Now, if somebody is asymptomatic, in other words, they don't have symptoms of COVID-19, but they needed their gallbladder taken out, we have to test that patient. So those protocols have to be put into place. Also, we have to follow the patients up as well post-operatively to make sure they don't develop COVID symptoms and things like that. So there's a lot. Plus, we have to still maintain social distancing in our clinics, in our operating rooms. We can't have an operating room that necessarily has as many people in it as it used to have in it, or a clinic waiting area that has 50 people in it. We can't do that anymore. So all these measures have to be taken into place. Now, similarly, those measures are going to have to be taken into account when we open up the rest of society. Restaurants aren't going to be able to have 200 people in there, at a particular popular restaurant here in town. But that doesn't mean that we can't get to that at some point in the future, but it's going to be when an appropriate vaccine is created. And let me tell you, I'm optimistic. I really think, Aaron, that we're going to get a vaccine sooner than we think. There's almost 80 vaccine candidates that are out there right now being tested. A lot of smart people working on them, so I'm very optimistic that it'll be closer to 6 months than it'll be to 18 months.
Mm-hmm. Dr. Ghali, I keep reading stories about the projections of hospitals across the country, especially big city hospitals, how they were going to be overloaded. They wouldn't be able to keep up with the number of COVID-19 patients. And that was part of the big part of the logic of eliminating elective surgeries and the like that you just referred to. Is your hospital there? Has it been overrun, overloaded? Are you filled to the brim with COVID-19 patients, or has the number that have been there, has it been fewer than anticipated?
I would say at this point it's been fewer than anticipated. I wouldn't, at one point we've had somewhere between 50 and 75 in the hospital, which is not an insignificant number, but it's certainly not the numbers that they had down in New Orleans, where it was, sort of a declared hotspot, or certainly not in New Jersey or New York. But, I would say that was a significant number, but it's not, I wouldn't say that we were necessarily overwhelmed. I want to knock on wood when I say that, because, again, it is very important. The whole reason of what you just said is, it's not like we've discovered a vaccine. It's not like any of these treatments, whether it's hydroxychloroquine or whether it's the inhaled nitric oxide or anything else that we're using or doing, has really jumped out there and said, okay, this is a treatment for this. No, it's totally because of the social distancing, the physical distancing, the stay-at-home order, and the fact that people started taking this situation seriously. And so that is what has resulted in a reduced number. And it's kind of one of these things where I'm happy that the model was a little bit wrong in the favorable side of less deaths and less hospitalizations. But it could go back the other way if we're not careful. That's why we have to know when can we take our foot off the gas. It's not quite yet. There's some things that can start reopening, and that's what the governor is doing with surgeries. It may be worse to wait another 2 or 3 months on this medical condition versus actually going and treating this individual. It could help prevent them having a stroke or having a heart attack or having some abdominal issue or their cancer growing or something along those lines. I think that's the rationale.
Dr. G.E. Ghali, let me ask you, you launched antibody testing at LSU Health. What are you seeing? What are the numbers showing here locally?
Well, I would say it's too early to tell, but I think that what we hope to be able to see is similar to the situation that they saw in California when they did some representative random sampling, which is what we're planning on doing. And this representative random sampling is really going to be able to assess how many people actually have antibodies to it. And then, our virology department is a very, very robust department, and Dr. Kevel is very sharp in defining how those top-notch researchers, what they're looking at. There's various tests that are specific to the antibody test, like a neutralization type of assay that would help actually determine not only the quantity of antibodies, but whether those antibodies have the ability to actually fight the virus. Because just because you have antibodies, from a quantitative standpoint, doesn't mean qualitatively that those antibodies are actually working. And so we have some tests that are being developed to help look at that specific situation. So what we hope to be able to see is that a significant portion of the population has developed some level of immunity to this virus. Now, I expect as time goes on during the summer, it gets warmer. We've discussed this before on the radio. These viruses all viruses don't tend to thrive as well in warmer climates. I think as the temperature gets warmer, the virus is going to dissipate even further, but I don't want us to let our guard down too much because I think until there's an actual vaccine, which again I hope is 6 to 12 months versus 12 to 18 months down the road, once the vaccine is out there and folks get immunized, then we can let our guard down a little bit more. We still always want to make sure that our hands are clean and we're not touching our faces regardless of whether we're dealing with this virus or not. But in general, we can be a bit safer once we've got a good vaccine that's in place and it's being administered to the population.
Doc, you had made reference to that Southern Cal study that extrapolating their antibody test numbers, they said as many as 440 some odd thousand people in the Los Angeles area could have already had the virus. Do you have any sense of what those numbers might be if you sort of compare them to the Arklatex? And B, that really throws a wrench into the projections that have previously been made, doesn't it?
Well, it does, and I'm glad it throws a wrench into it because, it's throwing a wrench into it toward the side that there are folks that are getting exposed, and this sort of puts credibility back into the concept of, herd immunity, where, people are prone to the virus. They get the virus, but they have a fairly mild disease that develops, and they develop antibodies to it. And then ultimately, kind of like a Pac-Man machine, the virus ends up in dead ends and can't go anywhere, and then the virus no longer thrives because it's sort of like a mosquito. It has it has to have some kind of host to hop onto in order to continue to thrive. So yes, the thing is, and I would be careful too much, and I don't want to put too much faith in the California study. I've got a lot of faith in it, but I don't want to put too much into it from a number standpoint because they have a higher population density over there, and so they're more prone to spread it from one individual to another. That's what I think has saved us a little bit in North Louisiana, is we don't have the population density that some of these cities have, and particularly with asymptomatic folks that can carry it from one to another, albeit they have a mild disease, which again is how they're developing their herd immunity. Now, whether that immunity actually prevents them from getting the virus in the future or not is really up for debate at this point.